On behalf of Ali Hicks, Monique Harding, and myself, I would like to welcome you to our presentation on the Health Equity Guidance document we developed. This project was a collaboration between the Catholic Health Association of Ontario and Western University. The aim of this project was twofold. The first component was the creation of a white paper or policy document on health equity for the Catholic Health Association of Ontario, or CHAO. The second was to conduct a survey with analysis of results for the CHAO membership in the form of a PowerPoint presentation for distribution to CHAO members. As a group, we recognized the historical harms towards Indigenous peoples as a result of the 1969 White Paper proposing the abolition of the Indian Act, and therefore agreed to rename the project as a guidance document rather than a white paper. The overall goal of the project was to contribute to policy development and future strategic plans of CHAO members. For this project, we were fortunate to be partnered with Dr. Victoria Smythe, Dr. Marilyn Ford-Gilbo, and Dr. Karen Campbell. Dr. Smythe and Dr. Ford-Gilbo have conducted extensive research on health equity and equity-oriented healthcare and were fundamental in the creation of EQUIP healthcare programming. And Dr. Campbell worked closely with us as we moved through the process of writing the guidance document and developing the survey. The purpose of a guidance document is to summarize what is known in research on an issue, to present the implications of the issue, and provide recommendations. As a group, we started the project by conducting a broad literature search with the assistance of librarian Megan Stanley. Our first step was to explore what current research says about health equity and the populations most affected by health inequities. Since creating a guidance document is an extensive project, each group member took on the task of authoring different sections of the paper. We then worked collaboratively to create recommendations to the CHAO on how to incorporate health equity into their organizations. Through regular meetings with Dr. Campbell, we were able to work through the messy process of summarizing the literature, create actionable recommendations, and learn how to professionally write as a group. For this survey, we formulated questions on health equity and used Qualtrics to distribute and analyze the results. We then compiled that into a PowerPoint presentation as was requested at the project outset.
The significance of our project is multifold. Number one, our guidance document focuses on health equity. Health equity seeks to eliminate the unjust and unnecessary differences between individuals, including those at organizational, systems, or societal levels. In Canada, health inequities stem from the widening gaps in income, reduced social supports, racism, and continued discrimination and stigma towards people with disabilities and other marginalized communities. Therefore, our project is of significance because the document will guide the CHAO moving forward to address the multiple components of health equity. Please refer to the figure in this slide to learn more about the equity-oriented care process by EQUIP that can help guide practitioners in this process. Next, it is of importance to note that COVID-19 exacerbated health inequities. Those who experienced precarious housing and financial insecurity were more affected by the mandated closure of businesses, physical distancing policies, and mental health impacts of the pandemic than other groups of populations. Racialized and low-income communities also felt a greater health burden. Those living in apartment buildings and in cities had a higher incidence of mortality when compared to single-dwelling homes or rural communities. It is therefore important to discuss and guide organizations now more than ever in regards to health equity to ensure that these health inequities do not widen. The next part of our presentation, we will be speaking about barriers. Firstly, amongst the team, communication was sometimes a barrier. We found that a major barrier was finding a time to meet together as a group. We had quite a few members in our group, and one group member is situated in Vancouver, so on a different time zone. Eventually, we settled into a standard date and time that mostly worked for all group members. We utilized Teams, email, and messaging to ensure all team members were kept up to date with any changes or developments happening with our project. Next, we had collaboration. It was difficult at times to collaborate amongst many moving parts of our project. In particular, it was difficult to get responses from member surveys from the CHAO, which delayed writing certain sections of the paper. Finally, an aspect of the research was challenging. Our topic of health equity was extremely broad. This, in a way, was a barrier at the start of our project, because we had hundreds of papers to go through, even after refining them down from the literature review.
After reviewing hundreds of articles found from the literature review and then compiling our findings, as a group we were able to come up with the following recommendations for the CHAO on how its organizations can work towards achieving health equity in healthcare. Recommendation 1. Implement equity-oriented healthcare into health organizations. This includes making equity a priority within strategic plans. EQUIP, which is a well-established framework, can be used by organizations as it focuses on developing equity at both the knowledge and organization levels. Recommendation 2. Conduct health equity impact assessments and utilize data to inform strategies to address health inequities. Research has shown that social determinants of health have a strong impact on the health of various population groups. Organizations can use health equity impact assessments to identify health disparities between these groups, what their impact is on these groups, and where to target their investments in care. Recommendation 3. Focus on cost-benefit analyses. It has been noted that providing cost-effective, equitable health care improves the patient experience of care, the health of populations, and also reduces the per capita cost of health care. Therefore, it is essential for organizations to perform cost-benefit analyses to fully understand the impact of equitable care on the finances of the healthcare system. Recommendation 4. Maximize access to care for marginalized people in a timely, equitable manner. Equitable and fair access to health, as well as quality, timely care, is recommended to address healthy inequities amongst marginalized individuals. Removing barriers that prevent patients from obtaining care, such as poor transportation, additional fees, and unsafe or unwelcoming clinic spaces, can go a long way in providing fair access to marginalized populations. While working on this guidance document, we learned that timelines and deadlines are very important when working as a team. Each member is key to the development of the final project, and we all relied on each other to ensure that we met our imposed deadline. There's a degree of trust that is set out in each team member, as we needed to rely on each other and have confidence that each person would complete their portion of the combined work. The most rewarding part of this experience was that each member was able to contribute an element to the guidance document rooted in their area of interest or a goal they set out to accomplish at the outset of the project. Thank you so much for taking the time to review our presentation on creating a guidance document on health equity for the Catholic Health Association of Ontario. We hope you enjoyed it.